Osteoporosis, a complex chronic condition, by Zura Malik, Sunny Okocho, Jadushan Sandinathan, Alex Chokanov, Leela Cardano, and Sri Kobi Vijaykulasinghe. This is the synopsis of the presentation. We're going to talk about introduction, pathophysiology, signs and symptoms, condition complexity, osteoporosis as a chronic disease, epidemiology, rehabilitation strategy, related research publication, validity of the research publication, and pedro analysis. Osteoporosis is characterized by having a low bone mass or density. Bone mass is the measure of the amount of minerals contained in a specific volume of bone. So this loss in bone mass results in structural deterioration of bone tissue, leading to bones to become fragile and weak. So this image consists of normal bone matrix versus osteoporosis.
Osteoporosis affects mainly women over the age of 45 post-menopause. Risk factors include a history of fractures, frailty, and lifestyle factors like low calcium and vitamin K diet, steroid use, smoking, high-calorie diet with a lot of alcohol consumption, abnormal vitamin D receptors, lack of exercise, and failure to obtain peak bone mineral density BMD, which is estrogen dependent. The abnormal bone turnover is most prominent in low estrogen patients, so it affects women the most as men have more gradual loss of hormones. Peak BMD during puberty and early adulthood is the most important thing in preventing this disease, which is dependent on adequate nutrition and lack of illnesses that affect skeletal growth like anorexia. Bone mass is maintained by controlling the amount of bone breakdown by the osteoclast cells and bone formation by the osteoblasts. Osteoclast precursors become differentiated and activated into their mature forms when rank L ligand binds to the receptor on them. Osteoprogesterone, OPG, is produced by osteoblasts and connective tissue cells and inhibits rank L from activating the osteoclast and promotes bone building. Estrogen causes proliferation of the osteoblasts and increases the OPG produced, so it's important in maintaining a good rank L OPG ratio, which is the basis of maintaining a proper bone mass. In postmenopause, low estrogen causes reduced rank L system inhibition. Pathological fractures of the inner bone, are called the trabeculae, are very common in these patients, which are the affected areas that are thinned out and not contiguous, and these are the spaces that you can see in the stained micrograph that increase with disease progression. The disease starts deep in the bones, and as it progresses, the body compensates by increasing the thickness of the surrounding vertical trabeculae, which are the red boxes on the left image. The result is that the bone is more stable vertically and can resist vertical forces more than horizontal ones, so the person is very susceptible to vertebral and hip fractures, as these are the areas with a lot of load bearing. Curving of the spine outwards, kyphosis, is very common. The progressive thinning of the vertebral trabeculae means bone marrow is replaced with fatty tissue as the areolar trabecular space increases as a function of progression. Loss of connection between inner bone components because they thin out means that the patient's bones are less mechanically stable and more prone to fractures with reduced bone healing due to reduced perfusion because there's loss of hemopoietic tissue, so the body functionally adapts and reduces blood flow to the affected bone. Symptoms of the most common type of fracture, which is osteoporotic vertebral fracture OVF, includes outward curve of the spine, kyphosis, fatigue upon exertion, flank, back pain upon ambulation, disability, loss of height, and reduced quality of life. Psychosocial burdens, impaired functioning. So kyphosis can also restrict the person's abdominal space, causing weakness and reduced nutritional intake because of pain and discomfort. A common type of fracture is of the hips and causes excessive mortality of about 20%, and this is related to reduced mobilization after a surgical reduction with blood loss, high rate of pneumonia, cardiac failure seen in these patients who are 8 times more likely to die within the first 3 months after surgery. An issue with healthcare utilization is that fragility fractures often have postoperative complications such as venous thromboembolisms and pneumonias that require the patient to be hospitalized, and this exceeds the costs attributed to the acute fracture treatment by itself. Almost a third of hip fragility fractures require long-term nursing home care, where the person never regains their pre-fracture levels of mobility and independence. There's a big cost burden to the healthcare system. In the States, it affects over 10 million people over the age of 50, causing over 1.5 million pathological fractures annually, 500,000 hospitalizations, 800,000 ER encounters, almost 200,000 nursing home placements, and over 2.5 million visits to the primary care doctor's office, and this costs $12 to $18 billion per year in the United States. In the States, the likelihood of needing access to primary care is 14 times greater in the first year, with mortality risk increased by 10 to 20% after OVF surgery compared to the general public, which is quite burdensome.
Depression, an additional entity. Depression is a common mental disorder which is characterized by sadness, loss of interest or pleasure, feelings of guilt, disturbed sleep or appetite. Osteoporosis falls and depression have a significant tridirectional relationship. Excessive fear of falling due to compromised bone strength is frequently associated with depression and therefore also increase the risk of falls. Both depression and fear of falling are associated with impaired of gait and balance and diminished self-esteem, an association that is mediated through cognitive, sensory, and motor pathways. Treatment challenges. The possibility of falls can be increased by antidepressant medications. Increased risk of fragility, fractures are associated with serotonin reuptake inhibitors.
As we all know, chronic disease is a condition that lasts 1 year or more and requires ongoing medical attention while limiting the ability to perform activities of daily living. Based on World Health Organization, chronic disease is not passed from person to person. There are long duration and slow progression. More importantly, chronic disease can be often controlled but rarely cured. Osteoporosis is characterized by low bone mass and structural deterioration of bone tissue, resulting in the increase in bone fragility and susceptibility to fractures, resulting in individuals affected by osteoporosis to have difficulty performing their daily activities. Apart from this, osteoporosis can be clearly identified as a chronic disease due to the amount of time the condition lasts. For instance, osteoporosis is usually age-related, as prevalence of osteoporosis increases with age, from 2% at 50 years to more than 25% at 80 years in women. As the population increases, the incidence of osteoporosis and fragility fracture will also increase. Osteoporosis is defined as a reduction in bone mass and disruption of bone architecture, resulting in reduced bone strength and increase of bone fractures. It is responsible for more than 1.5 million fractures annually, including 300,000 hip fractures, approximately 700,000 vertebral fractures, 250,000 wrist fractures, and more than 300 fractures at other sites. Estrogens plays a major role in skeleton in order to conserve bone mass. Estrogens suppress bone resorption and maintain balanced rate of bone formation and bone resorption. Steps in conserving bone mass. First, it increases the activation frequency of basic multicellular units, which leads to higher bone turnover. Next, it induces a remodeling imbalance by prolonging the resorption phase and shortening the formation phase. As a result, the volume of resorption cavity is increased beyond the capacity of the osteoblast to refill it. Many factors influence the biological linkages in humans that regulate osteoporosis and atherosclerosis with calcification. Combined therapies now available may increase bone density and limit the growth of atherosclerosis progression. Understanding of the biological linkages will lead to dual purpose therapies that may ultimately prevent the adverse outcomes of osteoporosis.
Treatment and rehabilitation. While osteoporosis is considered as a disease impacting the physical ability of body and depression is categorized as mood disorder, a strong correlation between the disease and these two entities has been identified. With this in mind, physical rehabilitation is an approach being applied to combat the manifestations of both disease. Key points include reduction in pain and improvement in mood. This can be achieved by keeping patient engaged in physical activity, improved range of motion and muscular rebuilding, while initiate to increase patient's mental and physical signs and symptoms. This will ensure that the patient has an improved quality of life as patients start returning to their daily activities. Overcoming depression, a health belief model. Before breaking down all the important points, it's very important and essential to define what's the health belief model. It is a theoretical model which is used in providing more information for health promotion and the disease rehabilitation programs. It is used to describe, guide, and predict individual changes in health behaviors. In long run, an individual's course of action is often determined by his or her perception of the benefits and obstacles associated to their health behavior. So let's break down all the 5 points. Identify needs. Identify physical activities the patient enjoys doing. Communicate with professionals, which means address patient's beliefs to improve knowledge, confidence, and self-efficacy. Practice SMART goals. Specific, measurable, attainable, relevant, timely. Identify barriers and prepare for setbacks, which means have the patient communicate worries and doubts, be patient, and collaborate dynamically to develop new strategies as the patient encounters new issues. Finally, build a support community. ensure all teams are committed to achieving the patient's goals, and that adequate support can be accessed when required. It is important to recognize patients prefer physical activity. By this, we mean that the objective is to enjoy improving physical health. The activities should not be viewed as chore. It is also essential to practice collaborative approach through seeking help from a mental health professional. Why? Because cognitive therapy focuses on patients' belief and self-perspective. Therefore, therapy should view positive components in the patient's health, which can result in improving patients' confidence and self-efficacy. Finally, there is also a need to set achievable goals. By this, we mean design reasonable timeline in achieving goals to help patient understand that progress and improvement takes time. And finally, practice SMART goals.
Physical therapy as a rehabilitation therapy. Physical therapy is usually administered by a kinesiologist or physiotherapist. The purpose of physical therapy is to help the patient develop, maintain, and restore maximum mobility and functionality. The purpose of PT is to help people when their physical functioning is impaired or threatened by the effects of aging, diseases, injury, disorder, conditions, or other factors. The main goal is to maximize the patient's quality of life in areas of social, emotional, psychological, and physical well-being. Physical therapy assessment involves the examination of the patient needs, the evaluation of those findings, clinical judgments regarding patient care, which comes into play when formulating the diagnosis, prognosis, and treatment plan, all which involves the implementation of physical therapy in the treatment programs, while also tracking outcomes of those treatments and intervention plans. Physical therapy also helps to promote a patient's self-management skills. In certain situations, physiotherapists work with other healthcare professionals, such as physicians, chiropractors, and massage therapists, to help provide a more specifically catered treatment plan. Physical rehabilitation exercises. It has shown that certain exercises that are very effective for those with osteoporosis include weight-bearing aerobic exercises when they're combined with strength and resistance exercises. It is recommended that the individual does these exercises 3 to 5 times weekly for 30 to 60-minute sessions tailored to their specific needs. Weight-bearing aerobic exercises include low-impact sports, climbing stairs, jogging, walking, as well as Tai Chi. Strength and resistance exercises, which is defined by the movement of joints against resistance, such as their own body weight, machines, or weight produced by free weights, include exercises such as squats, knee extensions, hamstring curls, step boxes, lat pull downs, seated rows, and bicep curls, as well as tricep extensions.
This paper investigates the efficacy of using the Health Belief Model (HBM) to implement exercise rehabilitation in elderly patients diagnosed with depression and osteoporotic fracture. Through adopting a treatment approach involving a patient's physical and psychological recovery process, the prognosis is strengthened and the patient is more likely to improve his or her quality of life. This study also reveals that they are more likely to engage in recommended physical therapy activities by minimizing psychologically the perceived resistance, seriousness, increasing their perceived benefits and self-efficacy through behavior. This improves cognitive function while also enhancing bone strength and muscle mass. The result of this study showed that the incidence rate of depression and anxiety in osteoporotic fractures in patients is greater than 59%. In addition, physical rehabilitation advice has been shown to positively reduce depression symptoms in patients with fracture by enhancing their cognitive mood and also promoting wound healing. Therefore, analysis of scores from the HBM physical rehabilitation group after 3 months showed significantly low incidence of depression and anxiety relative to those prior to intervention, indicating that HBM rehabilitation activities have a significant effect on negative emotions change. Therefore, it is necessary to determine its internal and external validity when referring to an article in order to ensure that the information used is reliable and truly represents the data. The sample size of this analysis is 162, which is sufficiently large to represent the population as a whole with reasonable accuracy. In fact, the study uses 4 different scales to gather raw data to be evaluated by statistical software to show that after the study, there is a statistical difference. Finally, comparing this analysis to the scale of Pedro, it meets some but not all of the criteria. Meeting requirements are 1, 2, 4, and 10. The eligibility criteria were specified, which means elderly patients treated at 3 third-grade general hospitals in the province of Jiangsu. 2. Subjects were randomly allocated using the minimization random allocation method. And at baseline, the groups were similar with respect to the most relevant prognostic indicators. No statistically significance were found in the groups in respect to age, gender, education level, BMI fracture site, or socioeconomic status. The results of statistical comparison between groups are recorded for at least one important finding.
References that have been rightly cited by using APA format. These are the sites we used for the research for the osteoporosis as a chronic disease project. Thank you very much.